I don't know if that would do anything or not.
I think it's required. I don't know why it didn't yell at us, but,
This one magazine, they had 3 for $6 or something.
just make sure.
Yeah.
Okay.
They have a little bit of an arch in them, or padding or something.
Oh, it's cool. It's right after, but.
Recording in progress.
All right, well, good morning, everybody. Thanks for joining us. Some of you may know I'm Tony from Mercy St. Luke's Family Medicine. We're located in Perrysburg, just down the road on Dixie. And as we do the third week of each month, give a talk on a different medical topic. Today, we're talking about management of osteoarthritis. There's different types of arthritis, but today we have Dr. Salah Awadallah. He's going to talk about basically osteoarthritis. Certainly, if you have questions related to rheumatoid arthritis or some other questions, he'll be able to answer those at the end. But today, it's just a talk about something that probably a lot of us are familiar with. I've mentioned this before, but about 20 years ago, when I first started giving these talks and I provided a handout at one of the sites, somebody looked at it and said, "Old Uncle Arthur." And I said, "What the heck are they talking about?" Fast forward about 30 years and now I know who Uncle Arthur is. So
And nobody likes it.
nobody likes him. But he's just going to give a talk about, what is arthritis? How does it present itself? How do physicians come to diagnose that? What are some of the treatments, both pharmacological, meaning medication related, and things other than medication that can help with that. And as a family physician, he certainly sees this a lot. So I'll turn it over to him and we'll stick around in case you have any personal questions.
Thank you very much, Tony. Again, everybody, officially, my name is Dr. Awadallah. It's a hard name to remember. You guys can call me Dr. A. Hello, everybody online. Hello, everybody here. Thank you for having us. This is a very wonderful to be in. And a wonderful looking facility. Sure, I'll driving up here.
Yes,
Very, very nice
yes.
looking place. So today we're going to be talking about arthritis, specifically osteoarthritis. There are many other types of arthritis, but today we're going to be talking about osteoarthritis. Generally speaking, it is the most common type and it affects about 1 in 7 people. And I think always the best way to start a talk is just defining what arthritis is. Now, generally speaking, osteoarthritis is an inflammation within the joints, okay? And the way it presents, specifically this type of arthritis, is it generally presents in 1 or more of your joints. And this is known as the wear and tear arthritis. There's certainly a lot more that goes into it than just wear and tear, but for the purposes of this lecture, we're going to just basically keep it as simple as possible so that you guys understand a little bit of like the foundation, the real reasons of why it hurts. And so the way this generally presents is you're going to have pain in your joints. Generally speaking, the pain worsens throughout the day because this is a wear and tear type of arthritis. You have a cushion between your bones known as cartilage. Cartilage is a type of tissue that doesn't have a blood supply to help repair itself. So your muscle gets hurt, it has a blood supply that can bring the nutrients, the white blood cells that help repair. It's a different story with cartilage. You don't have that. And so generally speaking, you're going to have pain throughout the day, it worsens throughout the day. You don't really have as much stiffness associated with this type of arthritis like you do with other types of arthritis, like rheumatoid arthritis. Generally speaking, the pain is relieved with rest. Sometimes it's also relieved with cold compresses and whatnot. And it's worse at the weight-bearing joints. So joints like the hip, the knees. You can also get it in the hands, but that's generally a little different. You get it in the hands because of overuse, not necessarily because of the weight-bearing joints. Okay, and we kind of spoke a little bit about how it presents. Generally, it presents the pain, it worsens throughout the day. It's less associated with stiffness. And it's mostly at the weight-bearing joints, the hips, the knees, the feet. It is also in the hands, but less so. And we always like to talk about how it's diagnosed and what are the risk factors. Generally speaking, the way we diagnose osteoarthritis is a simple physical exam. It looks like a duck, quacks like a duck, sounds like a duck, it's a duck, it's gonna be arthritis. So when somebody comes, oh man, I've got some pain kind of in my knee and it's painful more after use or after exercise or later on in the day, I find like it's swelling a little, it's a little painful and it's not in any other knee or any other place, it's a single joint. That tells us it's more osteoarthritis. If you told us I've got both knees are really painful and both knees are always red and inflamed and angry and it feels really hot and warm, that tells me it's a different type of arthritis, okay? Especially the age, because now we're talking about what are the risk factors. Age is a risk factor for osteoarthritis. The longer we're alive, the longer we're moving our joints and using our joints, the longer, the more wear and tear we have, the more the cartilage is kind of eroding a little bit, okay? Obesity is a very big risk factor. The more weight you have on a joint, the more pressure it's gonna have and the more wear and tear you're gonna have on that joint. Trauma is a big risk factor. If you have trauma to a joint, and this is kind of one of the things that I mentioned, I said it's a wear and tear disease, and I wanted to kind of keep it simple, but if you have trauma to a joint, generally speaking, what ends up happening is you start kind of this inflammatory cascade. And when you have trauma and you have these white blood cells go to this area and your immune system kind of tries to fix things, it recruits more inflammatory enzymes. And those inflammatory enzymes, if you don't use medications or treatments or get it fixed, especially in the acute setting where it happens suddenly, and you don't get it fixed for a prolonged period of time, you have these enzymes that basically erode the cartilage. Okay. And then overuse. So if you're, for example, cleaning the house a lot of it and you're on your knee, and you're always just on your knee and banging on the floor, or using your arm to kind of as a carpenter, or if you're typing a certain way or sitting a certain way for a prolonged period of time, generally speaking, that's gonna be a risk factor. And so some of these are modifiable risk factors like the obesity, smoking cigarettes, also another risk factor. These are things that we can modify. We cannot modify our age. We cannot modify certain other risk factors like previous history of trauma. But what you could modify is your exposure and limit the trauma, or for example, use pads on your knees if you know you're going to be on your knees, or one of the yoga mats or whatever it is. So these are always suggestions that I give people. Wearing nice thick cushions and things like that also kind of help with pain. And so what are the non-pharmacological management you can do for osteoarthritis? One of these is exercise. Now this sounds kind of counterintuitive. Man, come on, doctor, you're telling me to exercise. I've got knee pain, you're telling me to go run or walk or something like this. And there's some truth to that. So if you do have, let's say, knee pain, for example, because that's one of the biggest complaints people have, and you say, hey, you're telling me to go exercise. Well, the point of the exercise is sometimes it kind of helps stretching, okay? And it helps strengthen the muscles around the knee joint to help stability, okay? And it helps with flexibility. Now, the other things that you can do is physical therapy and weight loss. Obviously, physical therapy helps with the stretching and flexibility. The weight loss decreases the amount of weight you have on the joints, right? And then the warm and cold compresses can also help. The warm and cold compresses help with reducing the inflammation and swelling, and sometimes numb out the pain. Warm compresses, the idea of warm compresses is if you put something warm on your arm or leg or something, it dilates your blood vessels and helps more nutrients and repair and kind of those enzymes come to you there. And that kind of is the idea with the warm compresses. But with cartilage, one of the problems is it's avascular. There isn't. Your cartilage doesn't have blood flow, so the warm compresses are limited to fixing the actual joint, but could help with the muscles and the structures around the joint, which could provide relief, because those could also be irritated. So what are the medications that we can use? The most common medication is going to be something called NSAIDs, non-steroidal anti-inflammatory medications. Those are things like ibuprofen, Motrin, Aleve. Now, one of the problems with these is it affects your kidneys. And it also could affect your stomach lining. So if you have a history of gastric ulcers or kidney problems, those are a no-go. You should not be on NSAIDs. Tylenol is a medication you can take, but it showed less efficacy and effect for arthritis because it doesn't help with inflammation.
Not even the Tylenol arthritis.
That is specifically for arthritis.
Right.
So that helps.
Oh,
But
okay.
we're talking about general Tylenol, no.
Okay.
Tylenol arthritis is something that can help and it's adequate.
Okay.
But they do have a specific formulation, Tylenol arthritis. So the other things that you can do is, let's say you're not allowed to take NSAIDs like ibuprofen or Aleve because it could worsen your stomach ulcers or worsen your kidney function. There are direct injections that you can use. There are two types of injections: steroid injections and gel injections. Steroid injections are anti-inflammatory medications that are injected straight into the joint, decrease your inflammation, and provide immediate relief. Generally speaking, they last about 3 months and you can get them about every 3 to 6 months. The drawback with steroids is that it worsens the tendons and things like that. And so it's used as a placeholder. If you know you're eventually going to get a knee replacement, you can use steroids and you can use it for a year, 2 years. You know you're going to get your knee replaced. It's a matter of time kind of thing. If you are not in significant amount of pains, you can do something called gel injections. Now, gel injections contain something called hyaluronic acid. Your joint, specifically, there are many different types of joints, and I don't want to get into the nitty picky and really get really specific, but your joints have a capsule, and they have something called hyaluronic acid within those capsules. And so the gel injections are hyaluronic acid, and you can inject them in there, and they increase the amount of cushion in there. The drawback with these types of injections is they do not immediately provide relief. So if you are in such pain and you need immediate relief, this would not be necessarily the best route for you to go. But it does lasts longer. So if the effect starts within 3 weeks to a month, it does last longer, up to 6 months of relief, 6 to 12 months of relief. And you get the injections, I believe, about every 6 months. You can do that at your OB's office, not your OB, your orthopedic surgeon's office. And so those are the differences between those injections, the steroid injections and the gel injections.
The gel injection, where does that go in your body? Does it just dissolve? Does it?
No, it's so similar to the steroid injection. They go straight to the joint that's causing the pain.
Okay,
So if you have a knee problem, they can do instead of doing the steroid injection, they just do the gel injection. It goes to the same joint.
but does it wear off? Does it just disappear? Does it, does it stay in your body?
It's gonna stay
It's
because
gonna
it's
stay.
a natural part of your body. So that joint, the joint, there's a capsule. It's usually surrounded with a capsule.
Okay.
Within that capsule, there's hyaluronic acid that's naturally occurring. And the injection is hyaluronic acid, so it just kind of helps
Just
build up.
adding to it.
Yeah, just
Okay.
adding to
So
it.
are there side effects to it?
I think there are side effects to anything, any medication. Specifically, I mean, when you're adding a foreign object like a needle, they could be injecting, you could be adding a contaminant, right? So you can get contamination, inflammation, maybe you have a negative side effect to this artificial hyaluronic acid, some kind of allergic reaction. And then you've got, hey, they injected in the right place, right? So this is not a joke. So sometimes sometimes a lot of these orthopedic surgeons, they don't necessarily use imaging. Some people use ultrasound. Now, the drawback with ultrasound is it's a costly thing and it's time consuming and not everybody knows how to use it. So a lot of the trained physicians, back in the day, they'll just, use the landmarks and stick it in there and inject. And generally speaking, it works I think about 80% of the time or so. And so that's a good enough number for most physicians not to get the training they need for ultrasound guidance. And also, it takes a lot longer to learn how to use an ultrasound, and an ultrasound machine is not cheap.
I'm a naturalist, so I wanna go the most natural way.
Yeah,
And
yeah.
I thought maybe that would be it, but
It would be a good way, especially if you're not in considerable amount of pain to begin with. Right, if your pain level is tolerable, I would highly recommend doing the gel route.
and can they do it anywhere that's having an issue, like my ankle is the problem?
That would be a better question for the orthopedic surgeon
Gotcha.
and his comfort level. I've seen it done in the knee, the bigger joints. How they react or how they deal with the really small joints is a different story. Now, I don't have enough knowledge in that specific area to provide an adequate answer. And I would feel a lot better if you got it from the horse's mouth, the orthopedic surgeon. Because there are different types of orthopedic surgeons, right? There are orthopedic surgeons who specialize in shoulders. Some specialize specifically in the leg and the foot and the small joints. So I would certainly hear it from them, but I don't feel like I haven't seen it done specifically the gel injection within like a toe.
Right.
I've seen it done within the knee, generally speaking. And that's where they usually go for that.
Yeah.
But I have seen steroid injections done within the toe. So if a steroid injection is done there, and it's not a very painful thing, these injections. Has anybody had them?
Yeah.
Oh, yes.
Yeah.
The only problem is that I have type 2 and it raises.
Your blood
Yeah.
Correct. And so again, there are side effects to everything, right? Some people shouldn't be getting the injections or could get them just some close monitoring. Maybe they need to increase some of
I
the
have to give it a
medication.
longer period.
Correct.
between, you know.
Correct. Some people have contraindications or aren't supposed to take the NSAIDs because of the other problems they're having, right?
Right.
And so that's why it's up to the physician kind of to understand the patient as a whole and pick the best route.
I ended up
Ridiculous
having the
question.
surgery, but I was getting the steroids before,
Mhm.
and my surgeon said that every time that I get one, it's less effective.
Yes,
Yeah, that's.
So you can't do it for a long time
right,
because you're not gonna be
right.
No,
helped as much.
Right, and that's why I kind of said it's used like kind of as a placeholder. You know, you're eventually gonna get your replacement, you'll use the steroids,
Right.
right?
I'm very familiar with the steroid shots. And not the gel, but I'm assuming, don't question, if my insurance covers the steroid, it's gonna cover the gel. Yes.
Most likely, and one of the things they do is they make sure they generally inject you with steroids first. And they say, hey, you've had a good reaction to steroids, you'll have, generally speaking, a good reaction to the gel. So a lot of times, a lot of what the orthopedic surgeons will do is they'll inject steroids first, they'll see how you react to that.
And how long it.
Yeah, and how
lasts.
long it lasts, correct? And they'll say, hey, man, they had a good reaction, it didn't last as long, I think they'd have better results with the gel injections. Now, we kind of spoke about medications. There are other, obviously, medications you could use, like painkillers, like opioids, but those are generally not recommended. You know, they have a lot of side effects, they don't usually work as well for osteoarthritis, because they don't reduce inflammation. We'll talk a little bit about supplements. Now, there are supplements that have been shown to be effective, like the curcumin, turmeric. Those have shown limited efficacy and effect. They work to a certain degree. Medicines that don't work as much are things like glucosamine and this artificial cartilage and whatnot. But if, as a physician, if I feel like you feel like these medicines are working for you, then take them. You know, I'm not against these things. As long as it's not something crazy. And then obviously the final thing would be surgery. You've tried everything. You've tried the steroid injections, you've tried the NSAIDs, you've tried the gels, nothing is working. Ultimately, that's the kind of the final straw, and they'll do the surgery and they'll just replace the joint for you.
I had that done. I have a question.
Yes, ma'am.
Do you believe that I have several friends who have arthritis and they went off of dairy?
You can buy it.
Do you think that helps?
Off of dairy,
Yeah, because I am a cheese person and which isn't good in the end.
Oh, I see.
you know, when people start talking about dairy products and diet modification, I feel like that provides a systemic, meaning a whole body change. I don't feel like it specifically affects your joints, but I feel like it affects your whole body, and your whole body may benefit.